of Health Policy. I'm making it up as I go, but I know it is a major program and department at GW. She has and is an internationally renowned leader in comparative health systems in this work around workforce. Before going to GW, she had a major role as executive vice president. That's exactly what it was. We're changing it as we go at Academy Health, and that's where I knew her for many, many years. Many of you will be coming in June to the very extraordinary meetings that are hosted, that are the top lead meetings, health services research, and Polly was responsible for many of the programs that have made Academy Health the leading health services research organization today. So we are delighted. She's been instrumental in our work, been a participant in INQRI's annual meetings. So we're really thrilled to have you as our moderator to lead this panel today.
Well, I guess we have the option of using the table mics or this mic, but I'll start off here introducing our panel. Thank you, Mary, for inviting me to moderate this panel. Attending these meetings is always very interesting. I come at nursing from sort of through the lens of a foreigner, looking at the natives. I study you guys. I'm an anthropologist, and I'm fascinated by what I see and what I find. And I have to say, on this issue of implementation science and translational research, I've been working on that issue from the point of view of research to policy. And of course, we all, the idea of research to whatever it is, policy practice, began on the clinical side. So for me, this panel is very interesting because it's right in the middle. It's really about organizational practice as opposed to clinical practice or policy. And we think about the lessons learned from those of you who are interested in applied research and making sure the research has an impact. I think there are real differences between those three levels, clinical, organizational, and policy. And I was thinking as I was coming in this morning about what those differences are. And I think one of the, I mean, there are two aspects to it that are special and interesting. One is that most of organizational practice has never been questioned. It's just, you know, it's 100% assumptions, and you do things because they've always done that way. And then you introduce this notion of evidence, and it's really quite a revolutionary concept. You know, evidence in clinical research, it may not always be adhered to. In fact, it usually is not adhered to. But it's much more inherent in sort of the decision-making about what the practices are. But in organizational practice, it's really an especially new concept. The other part of it that it seems particularly interesting for this group, while many of the researchers are faculty, some of the researchers are also practitioners in those environments. And I think when, you know, for those of us who thought about how do you make research matter, it's really all about the definition of the research question. And so if you have research questions that are arising from the practice environment, it's because there's an intuition, because there's experiential knowledge. It would lead you to believe that this needs to be researched. And it's much more likely, I think, for those kinds of research questions that they're going to have relevance to practice than in the policy realm, where we can think up any crazy idea and it may or may not be very relevant. So there's something about this middle space that is deeply embedded in reality and in the trenches of how we deliver care. And I think for both those reasons, it makes it potentially much more exciting and vibrant area of evidence-based practice research and implementation science research than you would find at the other two ends of that spectrum. And I think the INQRI program has been obviously a catalyst for making this area come alive in a way that it never had before. So it had many objectives as a program, but I think from an implementation science perspective, the contributions are fabulous and only just beginning to be understood. So the purpose of today's panel is, in fact, to reflect on some of those lessons and to think about how to, I believe, put them in a language that not just those of you in the field of nursing research can understand, but those on the outside in clinical and in policy and in other areas of patient safety research, for example, can reflect on by understanding the similarities and differences in the way you all have approached this. Control your limbs. The focus now turns to our panelists, hopefully on the upper part of their bodies. I'd like to introduce Marita Titler, who is a professor and associate dean of clinical scholarship and practice development and the Rita G. Dumas Endowed Chair at the University of Michigan School of Nursing. She's also the division chair of health systems and effectiveness science at the University of Michigan School of Nursing, the director of community engagement and research core, and of the research core of the University of Michigan CTSA. So obviously a lot of interdisciplinary research experience happening on that front. Dr. Titler has 2 research projects funded through the INQRI program. The first focused on the National Quality Forum nurse-sensitive measures and processes of care to prevent falls. The second built upon this work to implement and evaluate fall prevention interventions targeted to patient risk factors. Next, we have Deleise Wilson, a first-year postdoctoral fellow at the University of Michigan School of Nursing. She's a member of Dr. Titler's research team. Dr. Wilson's research program focuses on the impact of organizational contextual factors on the implementation of intervention studies and patient outcomes, the topic of our panel. Barbara Resnick, next to Deleise, is a professor at the University of Maryland School of Nursing, and the Sonia Zaborkin-Gershowitz. All of these endowed chairs have these unbelievably difficult names.
It comes with the money.
That's why they had to have the chair. Chair in gerontology. That was the important word. She combines clinical work in a continuing care retirement community with teaching and research focused on optimizing function and physical activity among older adults across all settings. Dr. Resnick's INQRI project was a randomized controlled trial to test function-focused care, an intervention designed to maintain and improve function, physical activity, muscle strength, psychosocial outcomes, and decrease adverse events among assisted living residents. And lastly, we have Leah Shever, Director, Nursing Research, Quality, and Innovation at the University of Michigan Health System. Dr. Shever works in a clinical setting implementing evidence-based practice to improve quality of care for patients at the University of Michigan and has a program of research focusing on how nursing care impacts patient outcomes. She is a member of Dr. Titler's research team. We will have a brief presentation by Dr. Titler first. Then I will kick off the conversation with a few questions to our panelists, and then we'll open it up for general discussion.
And I will try and be mindful of not tapping on anything up here. So what this paper is about is 5 INQRI implementation studies, and we actually interviewed the PIs of the 5 implementation studies to understand the challenges and the opportunities and the excitement around implementation research. Deleise Wilson and Adam did the interviews, and then we did qualitative analysis of those interviews. We also have 2 INQRI case studies that are presented as case studies to learn about how the investigators really disseminated their findings and the kinds of impact those are having in terms of quality of care and on patients. Now, some of the people that we have actually interviewed are in the audience, so I'm hoping we'll have a lively conversation with them as well. There's just a few key messages I want to leave or have us think about as we talk about this today. One key message is about the implementation interventions. These are multifaceted interventions. They have several implementation strategies embedded in them. And so when you go to write up these complex interventions, it's challenging. It's challenging when you're reporting your study results. What are the key components that you should report in those study results? And understanding that that these implementation interventions are process interventions. It's not an event, it's a process. And there's multiple components of the implementation intervention itself, and there's multiple components of the clinical topic, if you will. And so you have to pay attention really to both components, the clinical practice that you're trying to change as well as the implementation intervention. And one of the things that we heard repeatedly from the investigators who were doing these implementation was that the time was short. Some of them are very worried about what they're going to find as they're wrapping up their studies, because by the time you get to the implementation phase, most of them were 4 to 6 months. That's a short time frame. So an example quote is, the biggest challenge was we had such a very, very short time frame in terms of implementing the intervention. That was one of the things that was so hard, was that it was such a hard time frame to get this up and running, to study the outcomes and also the processes. And then another investigator said, I'm very worried that we didn't give the units enough time to make changes. The second message is about context, and we talked a little bit about that in our other presentation, but I thought this quote was just said it all. So this investigator said, so in implementation science, it seems that context is so important. You know, obviously this is a big lesson. So that, I think that's very important. And so what is it about context? When you do this kind of work, you're working with practices, whether it's community practices, primary care practices, hospital practices, in which the sites are dynamic. They're ever changing. You may go in tomorrow and the culture might be a little bit different than it is today. And the people you're working with may actually decide to change the implementation intervention or modify it somewhat to fit their local context, which is, in my view, probably okay. But what are the key components that we have to retain for the implementation intervention? Do we always have to have the audit and feedback as we had planned? And what components of the implementation intervention must be done for success? And then, as we talked about this morning, what are the key context factors that we must measure along the way in the context? Several of the investigators talked about packaging their materials for widespread use. I know Dr. Resnick has done a Train the Trainer program. A large number of tools and materials were developed in these studies. The investigators shared those with us. The pain quality toolkit, for example, was used and will be updated and made available to the public. Others plan on packaging their materials into a toolkit. And others are already disseminating their materials in regional and national meetings as we speak. So what about the funding for creating these training materials and toolkits? You know, again, that is an area that we really need funding for, is to put these materials into a comprehensive toolkit that is usable by practitioners. And that's no small task to do. We have to do that if we want to scale up, if you will, what we have found from these implementation interventions. And then lastly, I would challenge us to really think about, from these toolkits, doing large dissemination studies to look at the effectiveness of the tools in the toolkits. And that's going to be important work and also will require funding. Now, a couple of these studies really talked about nurse manager roles, and so I wanted to call our attention to the importance of mid-level managers. And until very recently, we haven't paid much attention, I think, if you will, in terms of their role development, how important they are to evidence-based practice. You can have organizational leadership, but it's really happening at the unit level. In one of the studies, the nurse managers, this is actually the study that Leah was involved with, the nurse managers had limited knowledge about fall prevention research. This really led to a study in which she was the PI about examining nurse managers' knowledge and behaviors that facilitated adoption of evidence-based practices. And this has led to a publication in the Western Journal of Nursing Research, in which we learned last week was one of the top 10 most accessed articles over the past year. And so there is a lot of enthusiasm for this area. And we have also been invited to collaborate with our Canadian colleagues on a planning grant, which has been funded to address nurse manager role in translation science. This is another quote that I think says it really well. a noted author, is currently writing a whole chapter about the nurse managers and how important they are and how important this training is to their development. So this was one of the translation studies that focused on nurse manager development. It's a training program, 5 days, but a month apart, so they could actually apply what they learned in the training program. So that will be widely disseminated and read and will, I think, raise the consciousness about the role of nurse manager, how important it is to patient safety, and how we really have to seriously and thoughtfully plan for the development of the nurse manager. The next key question that I would ask is our payment for avoiding adverse outcomes, is it working? Is it really working? I don't expect you to answer that, but I would like you to reflect on that. And what about payment for interventions that have improved outcomes? So the focus function care component that Dr. Resnick does, that philosophy of care of increasing physical functioning, she has multiple publications, multiple reports that this in fact works. And how do we get reimbursement for that? There's also a multitude of studies, not just from INQURI, that show that evidence-based pain management actually saves money and improves quality. And how are we going to make sure that gets reimbursed? And perhaps we should be asking reimbursement for appropriate evidence-based care and nursing. Okay, what would that look like? And again, I don't have an answer to that, but what might that look like? And then I think we do have to pay attention to resource allocation. And that is things like a nurse manager development program do take resources. There is a need for human capital for implementation, okay? So we have to really think about how do we integrate that into workflow and what is the human capital that goes into that and how do we allocate resources for that. So before we open this up for questions, I would just like to say that I think that the potential impact of all the studies has been and will likely continue to be transformative and far-reaching. So the study on nurse manager development clearly recognizes the importance of that role to patient safety. Optimizing function and physical activity in older adults clearly has been demonstrated to improve care and improve outcomes, and I want to be in one of those assisted living places where I get a band every day and get to stretch that, right? We are changing how fall prevention is approached in hospitals. We are improving the state of pain management in U.S. hospitals. And as someone said, the next big campaign for critical care is going to be on addressing delirium in the critical care units. And we are empowering nurses to have a far-reaching impact on patients with substance abuse. So in summary, before we open this to questions, I would just like to congratulate all of you who have done implementation studies. Thank you for taking time to talk to us. We learned a great deal, much of which is in the paper and I could not cover today. Thanks.
Is this on? Yes. All right. So we will take questions here from the table. I thought I would kick it off with a question to our first author. So the theory of knowledge translation is that the strategies have to be tailored to the content of the intervention, the type of evidence-based practice, we can call that the what, to the context, which is both where and also when, sort of historically, and then sort of by whom, in terms of who the messengers are, who implement it, and also who the target audiences are. So those three levels, presumably, are critical in determining whether intervention X is successful or not. In other words, you would want to modify the intervention in Don Berwick's approach. You'd have to sort of translate it into that according to those three levels. So to make that theory come alive for us, I wonder if you could give us one example from the 5 cases that you reviewed where you could kind of walk through those 3 levels, the what, the where/when, and by whom to kind of make the theory come alive? How did a single intervention vary according to those three domains?
Yeah, excuse me. Yeah, I would say there are multiple implementation conceptual frameworks, and so I actually see those not as levels per se, but as components that we have to include in an implementation intervention. So if we're not really clear about what is the evidence base for the topic, and present that and have that dialogue with our physicians and nurses and physical therapists and pharmacists, and have what I call quick reference guides, or if it's embedded in electronic records to help them remember that is the what component that you're talking about. That has to be there. Secondly, you also have to think about the users of the evidence-based practice. Who is this going to impact directly and or indirectly, not only at the individual level, but at the patient care microsystem level. So if I am embedding this or helping to translate into a clinic or an inpatient unit, I have to pay attention to the culture in that unit. So for example, the study I did in finishing on implementing risk-specific interventions to prevent falls, I did site visits. I went to those places every 6 weeks. No matter how long one place it took me longer to get there than it did to do rounds. But it was actually important that they saw me, that I could, what I call touch and feel the culture of the unit. I could do point of care coaching with them. So I think that is the unit level, but also the individual nurse level. In those visits, I talked to the hospitalists about their role in implementing fall reduction interventions, that I really wanted them to look at the medications they were prescribing. So I think you have to do both, but I'm not sure they're quite as separated as we might like them to be, because who makes up an organization? It's individuals and how they interact. And then the third component is the context piece, which I've really already talked about. So for example, in the study I did a presentation to all of the nurse managers in the study units at each site. So they knew what that was about, as well as the physician group. Okay, so does that help?
Yeah. I guess there's always the counterfactual, and that's the problem with this kind of research. So you had a strategy, and you believe it was a strategy that you thought it would be successful, and then you evaluated it, and it was. So then the question is, would there have been a different strategy that would have been more successful? And we'll never know that. And particularly if we were to approach it from a cost-effectiveness point of view, it would be interesting to know, was this the most cost-effective strategy possible? So I guess I would push you all a little further in terms of what you learned about the lessons in a comparative sense. Like what would have been the choices that you could have made that might have made the outcomes better or worse? So maybe, Deleise, if you would be willing to kick off that line of reflection. I realize there are no quick answers.
Some of the people that actually did these studies are in the audience, so they may like to respond to that.
Well, we could do that. We were going to kick it off with the first line of questions to our panelists and then open it up.
Okay, I can use this.
Okay.
Well, thank you very much. Actually, I would just like to preface what I'm saying with that, just to give you an overview of these 5 studies that we looked at, that 4 of them were clinically based, and 4 of them were also multi-sited, and 1 was a single site, and there were several disciplines across, which nursing, pharmacy, psychologists, physicians, and physical therapists, just to name a few. And so in terms of the strategies that they use and how they are actually able to implement these particular projects, is that they use several different strategies, and for most of the studies it wasn't just any one particular strategy. And so, for example, they used workshops, online teaching seminars, webinars. They also use surveys, teaching. In terms of the workshops, they were sometimes like a month or a week long, or just an educational 8-hour day. And then to include, or to make sure that the education was sound, they included experts within the different fields to help in terms of their understanding of what it is that the topic that they were trying to implement. And at outside of that educational setting, within the hospital or the sites, they use opinion leaders or change champions. And then also to facilitate those strategies, they use several different types of tools. And Marita mentioned that the use of quick reference guides or toolkits for paying quality indicators or manuals or checklists or algorithms. And so the picture is that given the different types of contexts and different type of the design or the different types of the study or the kinds of users that they were trying to engage, they had to actually make those assessments of whether the strategies were comparative based on what they were finding on the ground. Because in as much as the study might have been designed with a particular toolkit, and especially in one of the studies, the investigator told us that, the staff, once they got involved and enthused, they helped to augment that particular toolkit and suggested ways in which it can be improved upon or which would have made it even more relevant. Also, what they found was that given the time, in terms of the time they started the study, or maybe the time lag between the educational preparation and the actual intervention of the event, they had to make certain changes. So it seems like it wasn't necessary. I wouldn't never ever say that it was all spontaneous, but the whole purpose of making sure that something was effective was really getting a full understanding of that particular context. Mm-hmm. And one of the things that really helped them to get a context, and again, we heard it mentioned this morning, and Dr. Titler mentioned it, it was that constant interaction with the sites, because the investigators had to be very flexible, but it was changing whether it was an online process, and it didn't work, because on some of the sites, the nurses were not as competent in terms of using that process, and so they had prepared an online survey, but then they had to present paper surveys where it wasn't possible. Sometimes they wanted to communicate with nurses by listserv, but just getting through the emails and all the different passwords, it just wasn't working. And just to really emphasize how important it was that these PIs had to be very flexible and understanding their context, this was one of the studies had 100 hospitals, and then one of them had 3. So could you imagine all of those separate sites with the separate units and all the end users and all the nurses, and so it meant that they had to be intimately in tune with knowing precisely what it was that they wanted to achieve and how to tweak it based on the context. And I don't know if that helps.
Yeah. No, that helps a lot. And I guess what I'm hearing you say also is that regardless of the strategy or of the type of intervention that you're choosing, it has to be an open strategy. It has to engage the people with whom you're working, and it has to be participatory, because that's the safeguard, because they can change it in a sense, rather than a priori selection based on some scientific criteria. You have to be willing to be flexible in the implementation and learn as you go. So. Leah, did you want to say something on this point before I ask the question of Barbara?
I just wanted to be cautious about that, because I think it comes back to your research question. And so I think there are times when it's absolutely appropriate, given your research question, about maybe what is the most cost-effective way to implement something, and you're actually comparing different strategies where you maybe would not want to vary from your set strategy. If the entire purpose is to get something into practice and to have care providers change the way that they're practicing, then I think, according to Rogers and others, then it's absolutely appropriate to be adapting the intervention to fit the context. And so I just want to be careful about that, because I think
it's a great example of how the research endeavor may at times come in conflict with the implementation endeavor, because you foul up your research question if you change the intervention. But of course you have to. Anyway, Barbara, on this issue of participation and engagement, do you have any reflections on how to make these interventions sustainable, and what you plan to do in your research area to carry this forward?
Yes, so actually that's what I was sitting here and thinking. There's a difference between dissemination and dissemination of information, etc., versus truly translation and then sustainability. And I was really going in my project for sustainability. Even for us, we actually followed people for 18 months, which was probably longer than most of the studies. Some of that was on my own dime at the end of the day, but that's another story. And to me, that's the really critical part. The other thing is to take it, and I like the philosophy of flexibility, because often, depending on what your intervention is, it's a philosophy of care that we're talking about. Not one model is going to fit everyone. And it's beautiful that we're sitting here in this room and talking about it when out in the real world, everybody wants the perfect pill. There's no perfect pill. And those of us that take care of patients know that, because there's no perfect patient. And they're not all the same. And so I think thinking of that flexibility, my project now I've taken from initially being 4 sites in the INQRI work to disseminating to a larger number in a different way, in that the touch has to keep getting lighter and lighter, which is another thing I think we need to think about when we're really talking about dissemination. How realistic is it to drive forever? And also, in terms of sustainability, the real thing is folks have to own it. It has to become within them, their philosophy. Otherwise, we've just implemented a project, very nice, thank you very much, and once you go home, it's all gone. How you do it is a whole nother book.
All right, we'll get into that in a minute. So, Leah, just to close this first round of questions with you, do you have any particular lessons learned from your sites? And I think we would be, the question we're all waiting to ask is whether the 2008 Never Events rule had any impact. Did you see any changes in your studies? But general reflections on lessons, and then some dirt, if you would, on this policy issue.
Yeah, I learned personally a lot from doing the study, and I think our sites learned a lot as well, which was actually, that was the most fun. If I start actually from the beginning, the enrollment phase was actually quite exciting, and I learned that sometimes it's good to not have, I shouldn't say this when funders in the room, but maybe it's sometimes good to not have the funding to get all of the data collected at each site. Institutions had to upfront make the commitment to collect this data because, quite honestly, we didn't have the money to fund a site coordinator or data collection person at every site. And so they engaged their own resources, and it was clearly a priority for the institutions. This problem around falls and reducing injuries from falls was clearly a priority if they were going to enroll in this study. And that made them hungry to participate. That made them very eager to hear the results. That made them actively engage. And so I think that was a learning for me. And I was also shocked. This was the first time that I've ever had sites call me to enroll. They had heard about, I don't know if it was through the initial rollout of INQRI announcements, but sites heard about the study, and they called us to say, can we please be involved in this study? And that was a lot of fun. For our sites themselves, we went through IRBs at over 50 institutions. And so both from my learning and that I learned a lot about IRBs, and VAs are the worst. But the sites hadn't gone through IRBs before in many of their locations, and so this was the first time for them and a learning for them about this is how to do it. These are the questions that frequently come up. It's not a bad thing if you get a question back from your IRB board. That's nothing to freak out about. And helping them go through that process, supporting them, that was a real win for them. They were really proud of that, and their sites, their departments of nursing were participating and doing nursing research, and that was a real source of pride for them. And so again, that was a lot of fun. I think both from related to implementation and evaluation specifically, our sites were shocked when they went back to their medical records. We had them do chart reviews, And on calls, I remember a couple of CNOs and their quality people saying, oh, this won't be too big of a deal. We've got an EHR. Can't wait to test this sucker out. You know, we're really excited. This will be really, really easy. And over and over and over again, we heard this was so painful. We had to actually reduce, we modified the study a little bit to reduce the burden because it was so painful for them. They found that things that they expected to be in the medical record, so some evidence-based interventions that they might have wanted to capture, they were not there. A couple of sites had staff nurses doing the chart audits, and the staff nurses looked at these and said, we are doing a really poor job with our documentation, and took that back to their colleagues and made changes immediately. The sites that thought they could give us a flat data file, they could not. And so all of our sites but one did hand paper audits, and over we heard that that was extremely difficult. And I think that's important both from the site, personal, the institution, because they told us that was difficult for them to evaluate care. We can't capture the care, we can't quantify the care, therefore we're not sure how that care is impacting the patient outcomes. So at an institutional site level, that was an important learning for them. And from a research team perspective, it was incredibly painful, and we are still recoding some of the information from those patient charts. We can't roll it up. So there's no standardized language in these charts, right? And so it becomes difficult to say, okay, ambulation here means walk over here, and this is how we're going to roll that up to quantify those interventions. The sites were very, very hungry to hear our results, and I think that was, again, another learning for me, that when they are actively engaged like this, they were hungry for the results to come out and wanting to be involved in those conversations. And they gave us research questions back, which I wasn't expecting. So we gave them the results, and then they said, well, that's nice, but how about this, this, and this? And that's why we're now going back through and recoding to answer their questions, which I think is a lot of fun. And so the million-dollar question, so the study design had pre-pay-for-performance and post-pay-for-performance. And so we did see a statistically significant increase, pre to post, around falls. So falls actually increased after the pay-for-performance measure was put into place.
Did I hear that right?
Yep, you did.
And
But falls with injury was the same. I mean, was similar.
Yep, similar. And I think and I don't know if we're going to get to it in a little bit, but it kind of goes back to, are we paying for the right thing, right? So I get the outcome piece, and I get not reimbursing for the injury. But I wonder if we were reimbursing for ambulation or mobility, if we wouldn't have seen the dearth. There was nothing in the patient's chart about let's get them up and get them walking. When we talked to nurse managers from all of these I can't remember how many units. 188 units. I don't think any of the unit managers mentioned that they were walking their patients to prevent falls or to build strength. So if we were reimbursing off of doing the right thing for the patient around getting them up, getting them ambulating, I wonder if it would have impacted some of our other results.
Interesting. So, wow, that's a whole panel in and of itself. So I think I'll stop here, and we have one mic for all of you. Many of you are authors of these studies that are included in the analysis. If you could just introduce yourselves and mention the topic of your project, we would welcome your questions. You want to start?
We did, let's see, I'm trying to see if anyone else on the team is in here. Screening, brief intervention, referral for treatment. So this was a cluster randomized trial of 7 hospitals that we're just finishing up now. So the idea was that we provided an algorithm for nurses who would screen patients with an initial screening question, and then if the screening was positive, then they would have a motivational interviewing and an algorithm where they'd help patients create a plan, which is not happening very often in hospitals. And I'm proud to say that we had an impact. So we're just getting the initial data back. But do you want me to hand it off to somebody else that participated? Or
sure,
okay.
And also if you have a question to throw to the group so that we can get a theme going here and pursue a line of questions that are related.
Okay, well, I had a reflection on some of your initial discussion, and we talked in the last session too, about the tension between explanatory trials and pragmatic trials. And I think a comment was made that about really defining what the intervention is, but I'm not sure that there's a tension. There's two different things. And tailoring is good in implementation and dissemination. So we're using interventions that should have already been tested for their efficacy. So we're not testing a new intervention. So this study is about spread, and all of the past research indicates when we think about individual adoption, it's about an individual being able to touch it, feel it, make it their own, a system being able to understand what it is and create a way to implement in their own organization. So, you know, an individual nurse's practice is nested within the unit, which is nested within the organization. So we're interested in implementation about external validity, not about internal. Well, I mean, we are concerned, of course, about internal validity, but this study is all about being able to spread it. So I actually didn't feel like it was as much attention as it is attention to the purpose of what we're trying to achieve in these kinds of studies. So I think that's somewhat of a comment and a question, too, of you know, how do we attain that balance, I think is the question for us when we think about implementation and dissemination.
Robin, essentially that's the REAIM model, perfectly described. And for those of you who are not familiar but want to do translation research, I think it gives you a nice framework.
Hi, Susan Beck, and several members of my team are here. We were involved in the Pain Quality Indicator project, which was the focus of this interview. And I guess I'd like to talk a little bit more about the dynamic nature because this is really a very challenging thing. And I'm, you know, for example, we had 326 hospitals, but just communicating with 326 places, in 1 month, you could have 10 places where the nurse isn't there anymore. I mean, you know, and so it really makes me pause to think, how do we translate in ways that will be sustained, that's not people dependent? Yeah. Because we focus a lot on education, but, you know, hopefully that person you've educated might go somewhere else and change practice, but it's like somehow we've got to hardwire these changes into the system so they'll last when the people move. And I'm not sure we've found good models to do that yet. That might stimulate some, maybe have ideas on that.
You want
So,
a reaction here?
well,
Yeah.
I will, and that's exactly what I do focus on because I'm glad to hear among my acute care colleagues this is an issue because, you know, in long-term care facilities, here today is gone tomorrow often. But the joke I always use is that when you're sitting at the nursing station and you hear one nurse say to another, that's just the way we do it here, you know you've won. And that's really what we're going for. So it needs to be a philosophy of care, and I think some of it is language. Language around what you call your programs and how you conceptualize them. And more, you know, I try and get rid of, for those of you in long-term care, the term restorative care. Medicare has made that a program, like physical therapy, that they reimburse. What we're often talking about in nursing is how we do things. You know, whether it's dissemination of what you want folks to do at the time of discharge. Ultimately, what we want is that to become your standard. And so I try and more to use it as language, and then again, you know, your whole, and I think Robin raised it beautifully, the system approach you use to translating that within the setting. But it's got to be the philosophy of how care is provided.
I also think that the implementation interventions or strategies that you use are somewhat dependent upon the phase that you're in. So when you're first starting to create change and trying to get people attention around that, I think it is about relationships, whether it's over the phone or over webinar, or it is about the relationships and how we have dialogue about why this is important to do the right thing. I think that as the change goes on, then the sustainability of how do you hardwire it into the policy and procedures, into the documentation system is the important component for sustainability. I think the lighter touch that you mentioned is important, but I think that when you're on a new area, this is me now speaking. I think you have to have some level of intensity to get it off the ground, to get it going. And if you stop, I think if you stop too soon, you have that start-stop effect, and that's not good either, because then people are not as likely to engage next time when you come back.
And another way to think about that is inoculation treatments.
Right.
So what can you use if you use a light touch, but we can never let go of that touch? And who may do the inoculation may vary. It may just be something that's set within the system.
And just to add to that, in terms of some of the hardwire findings that we got from our qualitative interviews, we did ask, how do you plan to sustain this, or how do you think this can be sustained once you're done? And actually we found there were 3 examples, and I think even with your study, Robin, where the tool was adopted into the EMR, in the electronic medical record, where the nurses are actually using it. The second thing was that the study with the nurse development, there was a lot of branding in terms of the concepts of the particular study. And so throughout the hospital, there was branding that she used, with, whether it was with the cups or with the mugs and those things, just to create some kind of a presence. But, you know, it's just sort of some sort of concrete examples of what they used. And then the final one, which I think we heard a lot about yesterday with Dr. Balas's study in Nebraska, where they were actually changes made, and for her it was interdisciplinary policy changes, where in terms of how they would approach the ABCD bundle, and I think that can probably help to maintain some sustainability for some of these interventions once they're done.
Other questions? Mary in the back.
I just would add to that, I think some of the answer comes from those end users who find the solution. So one of our participants came up with this idea on their whiteboard where they write, your last pain medication was given at this time and your next one is due at this time. Now, very simple, but if you hardwired that and it became the way we do it here, I mean, I think that could have a profound change in communicating with patients about their pain management. Yep. You know, so those kind of ideas, I think, can bubble up from some of these translational projects, and then how do we take that to the next level? So what we're hoping to do now is we've invited all the sites who've developed new tools to add to our, what we call our tool share on our toolkit. So we'll be able to take those ideas and spread them then to others who access it.
All of the investigators had examples like that, of where the end users came up with these wonderful ideas that they really supported. Yeah.
So I wanted to comment, the session on quality measurement, some of you were there, one of the challenges expressed was that we're in this overwhelming overload world of lots and lots of measures. And I wonder if you're experiencing in your work that we're in this similar world of organizations that are confronting 1,000 flowers blooming, lots of innovations that are occurring in implementation form simultaneously, and how it is that you disentangle what you learn. So Leah, your comment about falls and what was not the expected relationship, although no difference in injuries, wondering to the extent to which, you know, some of this is we're doing a better job of telling stories now in documentation than we've done before, but also maybe is it that organizations and systems have so much going on, so many opportunities that they focus on one and another slips. We've seen this in long-term care all the time. So I'm wondering if you can comment on, you know, the struggles or challenges that you had, because likely you weren't the only innovation being implemented at these sites at the same time, and yet the same people responsible for implementing it are responsible for implementing them all.
Yeah, so I would invite the other PIs to talk as well. Actually, one of our sites was bought by another healthcare system at the time, midway through. So that's a pretty dynamic change. But they still wanted to participate. Across the health system, they had decided, I don't know, maybe 2 or 3 months ago to actually do a system-wide fall component, what they call from the organization, very high multi-hospital organization. And so that's going to be somewhat of a competing demand as they move forward. The nurses talked a lot about competing demands. And so, you know, I think that we have to figure out what are the core nursing practice interventions, if you will, that must be bundled together to improve patient care and patient outcomes. And I think they'll look differently for medical surgical units than they will for critical care units, than they will for neonatal units. But I'm not sure we're bundling things correctly to make it easy for nurses to do the right thing.
I think I'd add to that and just say a couple more words, probably more from my practice life than this research study. But I think this speaks to sustainability as well. That helping the nurses critically think through these things and see them in a different way. That mobility isn't about just fall prevention this week. Mobility impacts all of these the patient in such a meaningful way about how are they going to get home and move around their house? Are they going to stay here longer because they're not up and moving? And helping, I think, see how this major important concept like mobility impacts all of these things across for the patient and their family, I think, is what helps both in terms of sustainability and to help the nurses really value when they're being told to do all of these things at once.
I would just agree and say, you know, sort of consistently, I think we're all singing the same song, that you have to bundle these things together, get people to see this is not a program, we're not focusing on one thing, we're looking at improving care in general and take it from that way. And I'm sitting here laughing. In long-term care, we're so used to it because you can never focus on one thing. Whatever you're doing is wrong. We're used to the abuse.
Yesterday, I was at the National Quality Forum doing a discussion about how they're going to package the Meaningful Use Stage 2 criteria, ultimately leading to Meaningful Use Stage 3, and looking at the fact that we've got thousands of measures, and out of those thousands of measures, we have really a few that we can assess at a real valuable level. One of the problems we came across is that there's, exactly what was brought up earlier, kind of measure fatigue. That there are so many things to assess that we can only assess so many. Some of the terminology you're using up there has actually been terminology that they've really been pushing out at NQF, which is hardwiring. According to Floyd Eisenberg yesterday, hardwiring is what we do to make sure things stop moving forward. If you look around the room and you see these plugs that you used to plug our computers into to get on the internet, you realize that we don't use those anymore. We don't carry around cables to plug into the wall to get on the internet. We have wireless. And that's really something to think about, is moving to a wireless thought system where we get rid of these legacy systems that lay behind and nobody ever uses again. And it's a terminology issue, really, that we want to hardwire things so that people think that way, but then later we want to unwire them so that they think the next way. And it's just really, if nothing else, this is just a thought issue and a warning that I think we have to be careful about the terminology we use, because those of us who are in IT are looking at that and we're saying, okay, so you want us to build this way, and then 2 years from now you're going to want us to build it another way, but we've already built it this way and we put a lot of effort into hardwiring it. So.
Well, I agree with you in terms of, I mean, that's a very thoughtful comment about hardwiring, and I don't disagree with that. I do think, though, our IT systems have to be as dynamic as care delivery. And our care delivery tomorrow is going to look different than it is today. And if our IT documentation systems can't support that, then I think we're in trouble. I mean, I don't know how, if we're supposed to document care delivered, then and it's dynamic and changing, then could I please have a system that could help me do that?
Well, let me just add one more thing to that. And Kathleen Charters and a few of the other folks that a few of us recognize the names. It takes about a year from idea to IT, a year and a half from IT to implementation, another year and a half from implementation to acceptance, and by that time it's already a new idea.
Yeah, so that's exactly my point. That is exactly my point. That care delivery of how we do that today and what we're changing today and expecting from nurses. Okay, so I'm an old nurse, right? So it was easier for me to actually pilot something and stamp it on a documentation form for 6 months to see if it works, so I could capture that, than it is to try now today to change an IT system or figure out where it goes in the electronic health record. I think that is a huge problem in healthcare, and I think we don't want to talk about it.
So, since we're in the medical record, electronic medical record space a little bit, I think there certainly are, I think Marita's bringing up the important point of the need for modular systems, model-based systems as opposed to and instead of hardwired, hard-coded content in our systems, we need very concept-based and modular type approaches. So there are architectural designs that will enable that. There's some pushes that need to be made in the vendor world in that space, but the more we have clinicians saying, hardwire this and hard code this into your system, the more embedded that and the harder it's going to be to move on. So that's one issue. Another issue, though, is this, I think it gets to the philosophy of what are we doing. The evidence-based care stuff, I think there's some good literature from Dreyfus and Dreyfus, some of the early knowledge management people, and they predicted that hard coding decision-making into electronic information systems would lead to some their study was based on Wall Street decision-making, would lead to some really serious economic decision-making stuff, and argued we need to look at evidence-based stuff as a safety net, not as kind of regressing everybody to a mean. So it's another philosophical perspective around evidence-based practice in terms of it being a safety net, not something that we have to be able to allow people to rise above evidence-based practice.
Are you
think
talking
about that as the floor, the safety, the floor.
Marcia, are you talking about clinical decision-making support that's built into IT systems, or are you talking about just capturing? I mean, because I think there's a difference. I think you can build clinical decision support systems to provide evidence-based care, which is one thing we could probably talk about. But at a minimum, we need to be able to allow a provider, a clinician, to document or to capture the care that they are providing. And hopefully, let's make it maybe easy to do those things which we know they should be doing as part of standard of care or of evidence-based practice.
Right. I think the decision support is absolutely one of these modular, model-driven type approaches where we have to make sure that our information systems are highly flexible, and as the knowledge base is changing, we can rapidly change the content that's presented to the clinicians.
Exactly.
And it's doable. But our legacy information systems are not built on technology that enables that. So it's going to be a while before the vendors can do that kind of turnaround too. I mean, it's a major change in the architecture of those systems.
I think it's time for closing remarks, actually.
Yeah. So you each have 3 minutes, 2 to 3 minutes.
Okay. You want to start, Leah? So instead of one person doing closing remarks, each of us are going to say something. You have 2 minutes.
I have 2 minutes? All right. Well, I just wanted to say that this was fun. Really. Both the session today and being a part of INQRI has been a great learning opportunity for me, a younger researcher. I've learned a lot and been able to hang out with some cool people, rub elbows with, Dr. Resnick here, which is really a lot of fun. And I think I was really excited that our sites, I think, appreciated it and they were engaged. And I think that we had a huge impact. 50 some odd hospitals, 180 some units. The questions that came out of this study, I think, were surprising to us, but a good question. So I just wanted to say thanks for that opportunity. Thank you, Marita, for a great mentorship, and thanks.
So I think since we're going down the INQRI philosophy, if you will, I think they've been a really good example where a little bit of money, because I don't know if all of you had studies, but it's a relatively small amount of money for a research project, really went a long way. And I think it really provided some very important, what I would consider more pilot type work, initial, whether it was small evidence or small evidence of how you disseminated something, but wonderful, wonderful jumping off research. So this is money that, hopefully the message will get out, was very well spent. Models that other funders could consider, because I know from my Robert Wood Johnson more money has come, not from Robert Wood Johnson, but from other sources, by being able to demonstrate things in a different setting for me, and then beginning to translate it further. So I think it's just a wonderful project from that perspective. And I certainly would hope and always did hope that the INQRI grants would continue to, in some ways, be in touch with each other, because many of the kind of themes across them are a wonderful way to build our strength as in nursing and nursing outcomes.
Well, I'd just like to say, as a brand new postdoc, I am totally deer facing the headlights, and I just can't thank my mentor, Marita, enough. And she's like, just do it. And I was like, are we going to go over this? She's like, no, just do it. So talking about implementation. But what I really gathered and I gained, especially from coming here for these 2 days, was just, and to me, it was really captured in the picture that we saw from Dr. Emanuel earlier today. And then the road that he showed us with many bumps, it only had 2 lanes. And from what I've seen, especially from what the PIs were doing, though that the road that the nurse scientists are on, there are many lanes. And for some of them, they even have overpasses. So I would really like to see how he would depict the changes that they will have to go through with the bumpy, multi-lane road and also with overpasses. So it, as a brand new scientist, I can totally say that this is an extremely rewarding experience and just totally energized in terms of moving forward and trying to see how much the contribution can really be solid in terms of meeting those goals that were set out by INQRI. And then from what we heard this afternoon, moving on into the nursing campaign for action. So thanks a lot, and thank you, everyone.
I'll be very brief. I want to thank Robert Wood Johnson for allowing us to come here today and asking us to do this paper. Thank you for being such a great hostess for us and a panel discussant. I also want to say thank you for each of you for the excitement you create around research and the commitment you make 24/7 to quality patient care, because I know it's on your mind all the time. Thank you to the PIs who were gracious enough to talk to us, and for those who filled out the questions so we could write the case studies. And so with that, I'm going to stop.
Well, it is, I mean, everyone loves to say lovely things at the end, but I do come away from this session with such an upbeat feeling of an enormous cohesiveness and the dynamics across the projects are really quite remarkable. You've managed to build a field here, Mary. No small feat, really, if not a social movement. So, do you have any closing thoughts for the panel?
Actually, this has happened because of you, each of you. So I am extraordinarily grateful, and I think healthcare is going to be the real beneficiary, patients and families, of all of your extraordinary investments. So it is the collaboration, it is the connection with each other that I think has been the most rewarding and will be going forward. So thank you. Thank you.